Good afternoon, everyone. It is truly an honor to welcome all of you from the NSU family, our university ambassadors, our community partners and friends to this important presentation. Community is a very clear core value of NSU, and service is part of the mission of every college here. Research and scholarship is a major component of the work of a university. And we know that both the science and the treatments will advance, and there's no probably greater example currently than COVID-19. And it's doubly an honor to get a chance to introduce one of my fellow deans, who I've had the privilege of working with, and I didn't even realize 5 years had passed already, and to really be front and center to see how he created, as founding dean, the Curative Patel College of Allopathic Medicine. His career is quite distinguished, been at Memorial Sloan Kettering, Duke University. He was the department chair at the University of Florida, has many grants over time. And his scientific, one of his major scientific accomplishments is in the area of vaccine development. But one of the things I wanted to mention that I was so impressed with was how he created an innovative medical school that's really, it's focused on the future. How do you educate students for the world that they're going to go into, to think critically, to communicate well, to solve problems, to work with other healthcare collaborators, to discover and to lead. And he has made significant headway in creating diversity in the pipeline of future physicians. So with that said, my honor to introduce you to Johannes Vivek.
So thanks, Karen, and thanks for the introduction. The good news is with Zoom, you can't see whether I'm blushing or not, but I did. I just wanted to welcome everyone to this Shark Chat seminar here, and the topic is, very timely. It's about COVID and about, how do we prepare for the current pandemic in the area of vaccines and therapeutics. I think really important topic, and I wanted to share some slides with you that we put together to show you a little bit, what the topics are. Today, I wanted to really go through my slides fairly quickly because I really appreciate the opportunity to address questions that many of you have articulated. But I just wanted to kick this off with a couple of facts that you might be interested in. So what I would like to talk about is, COVID-19 is a key mortality in the United States, in particular here in Florida. Talk to you a little bit more about Operation Warp Speed and how vaccines have been developed in a short period of time and how they have been distributed, including here in Florida. I wanted to talk about vaccines and monoclonal antibodies for COVID treatment and prophylaxis, and also talk about the variants, that have recently emerged. And you all heard on the news the new plans of the Biden government to look at COVID in a different way and hopefully accelerate both our population health as well as our economy. And then we are going into a discussion mode. Would like to start with the next slide. I think the reason for this seminar is also, the high degree of misinformation that we see daily in the news. There is a lot of uncertainty and confusion in our communities that are also have been precipitated through the elections and through other misinformations that are out there on the internet. So particularly social media has created a lot of confusion, what's going on. And I think that there has to be a responsibility at our level, particularly here at NSU, to give you good news and also provide you with the right sources that communicate appropriate news. And I can share with you a couple of sites where you get evidence-based information about the current COVID crisis and where you can get some guidance where to go. This is one of my favorite dashboards that I'm looking at every day that shows you actually in a very graphic way what's going on in Florida. You can see here that we have, about 1 million 1.7 million confirmed COVID infections and about 25,000 deaths, since March 1st. You can also see right now how many doses have been, given, to, folks 65 years and older and healthcare providers. So we just got started actually with vaccinating our population here in Florida. You can also see that Broward County is one of the hotspots for COVID. Everything that's kind of dark bluish has the highest incident of COVID cases, infections. And I think we need to talk about that, how to prevent, particularly in denser populated areas, COVID spread. I don't want to bore you with other information here, but here's the website, and I share my slides with you at the request. I just looked through the chat, and some of you asked, whether these slides are shareable, and they will be. I'll give you a brief update that came directly from the State Surgeon General. And you saw on the previous slide that second peak, which is really concerning. So the first peak was here in July, and we were all concerned and actually also very excited once the numbers came down through social distancing and other measures. But now we actually have exceeded that summer peak with more cases and worse outcomes, also mortalities that were due to the holidays, to more to the fact that we didn't socially distance. And the good news now is that by the end of January, I think we see that peak decline. And I hope that with vaccination, that peak will go down, way down to the initial, May incidence rates that we saw. So the State Surgeon General reported that the state is experiencing about 70 out of 100,000 cases per day in COVID cases, substantially higher than the prior peak, that summer peak that we had of 50 to 100,000 cases. This increase is due to person-to-person interaction and non-essential travel. That's a real issue, non-essential travel in the state around Christmas holiday, with a surge in cases starting 5 to 10 days later. So crowding, gathering, not mask wearing, traveling precipitates a rise in COVID transmission. And we should be very cognizant about this and avoid these exposures, particularly as we head into spring break and other events that might precipitate more person-to-person interactions. The good news is the rate of hospitalization, that means that people who got into the hospital was substantially lower than the summer. What it means is that we learned a lot of how to deal with COVID patients in the hospital, and some of the drugs and therapeutics that are now available have eliminated the need for ICU stay, and also for the ventilators that, in my opinion, are a curse and a blessing. If you have low oxygen levels, a ventilator is essential, but it is really hard to get you off a ventilator once you're dependent, and that has emerged as a major problem in hospitals, in ICUs. And the good news is that the mortality rates have to appear to have peaked by the end of January. So I think we're going down with cases for multiple reasons. Karen just asked me a little bit about, what is your risk of getting COVID, even in these days where we started vaccinations? And once I share these slides with you, you can read that hopefully better than you can read it here. The lowest risk is here, kind of opening the mail, getting restaurant takeouts, pumping gas, and playing tennis. But the high risk is really going to a bar, attending a religious service, going to sports stadium, and going to more crowded areas. So it's all kind of pretty common sense. But I think it's very important to remind yourself, even if you go to Publix, you are at moderate to high risk of getting COVID. It's just unavoidable. Even if you wear a mask, sometimes masks are not worn appropriately. Now there's a new insights that actually double masking might actually prevent the spread. And the Harvard folks are telling me with double masking alone, we can eradicate COVID. Time to be seen, but I just tell you, masking, appropriate masking, meaning that you wear your mask above your nose, is really critical. If it falls below your nose, you're not protecting yourself. Here, I wanted to talk about something that I found very interesting, Operation Warp Speed, because vaccine development typically takes about 10 years. from the inception, from the concept, from the idea to the clinical trial that really and the FDA approval that you need in order to apply vaccines or new drugs. And 10 or 8 to 10 years is way too long. So now, in midst of a COVID crisis, our government, bypassed the typical or accelerated the typical process through Operation Warp Speed that was announced in May of last year. It's a public-private partnerships where government and companies and researchers participate to select vaccine candidates of promise, accelerate clinical trials, and really help with production and scale of the vaccine to enable shots in each citizen's arms. The goal was to produce and to deliver 300 million doses of safe and effective vaccines by the end of 2020. That goal has not necessarily been accomplished, but now I think there was announced yesterday by Jen Psaki from the government that now all the doses for the entire population has been secured, and now they're working on the distribution, how to get it into people's arms. The vaccine distribution has been a bottleneck, and I tell you that the way it works is that the vaccines come from are distributed from the government, from HHS, the Department of Health and Human Services, to individual states like the Department of Health here in Florida. And we in Florida received about 250,000 doses per week in Florida, actually, and we needed about 1 million. So you can see we are still kind of behind, but that dose target is being reached, over the upcoming weeks as we broaden our eligibility criteria for vaccines that originally have been reserved for 65 years and older. The governor can prioritize vaccine recipients through executive order, so he does not have to abide by CCR guidelines. And our governor is focused very much on seniors greater 65 years and healthcare personnel with direct patient contact. So this is, drilled in us every week when we have briefings from the government or from the Council of Deans here in Florida, that these are the target personnel that we are envisioning right now before the general population will be addressed. I think the general population vaccination is only about 4 weeks away from now, and distributions are being prepared through CVS, Walgreens, also through mass vaccinations in churches and federal qualified health centers. I heard that even Disney is becoming a vaccination site as we move along and as more vaccines become available. At the present, the governor mandated that in order to receive a vaccine here in Florida, you have to be a resident, so you have to show your ID, or you have to be a snowbird with a Florida residence. I saw just recently lots of folks even from Canada and from South America lining up for vaccinations, and they were all kind of gently guided away from the vaccination sites because this does not meet the governor's orders at the present time. The initial distribution centers for vaccines were Jackson Memorial System, Florida Hospital, UF in Jacksonville, and Tampa General. But here in our county, the DOH has the biggest contingency, and you can see all these addresses that I'm happy to share with you that provide vaccinations to seniors and to healthcare professionals at the time. But as I mentioned before, we are going to roll this out now to the more global, to the more general populations, that is younger and that needs to be vaccinated in order to get protection that we need. The progress with vaccination is currently, we have 1.6 million Floridians that have received at least 1 dose of the vaccine. In California, we have 1.8 million, Texas 1.6 million. I think these are just informational data that you can digest on your own. And I wanted to also mention that the reactions or the allergies to the vaccine have been very, very minimal. So there were 30 severe allergic reactions reported in the United States, which prompted a little bit more precautions for those people, who have either pre-existing conditions or allergies, who should be, injected and observed in a hospital setting for 30 minutes instead of 15 minutes, as the initial recommendation was. What is our goal? And our goal here is really to reach herd immunity. It's kind of a confusing term, but it's very logic actually when you look at this by the third quarter of 2021. If you have more immune patients, if people are immunized, the spread of COVID is mitigated and is minimal. However, if you have unvaccinated people, one bad apple, one guy, one person with COVID can infect a large population here, as you can see. And this is here exactly the opposite. That's what we're trying to accomplish. It is also known that if a immunity that you can either get from an infection or from a vaccine, if it exceeds 60 to 70%, the virus will eventually die because it doesn't find any targets anymore to infect other people. So we saw this also with Zika and with other infectious diseases, but I tell you, the more folks, immunized people we have, the quicker the virus will go. And that's kind of the event that we are looking for. For those people who are doubting the efficacy of vaccines and are concerned or have reservations about getting vaccinated, these are just statistics that can't be denied. When you look at diphtheria, influenza, measles, and mumps and others, you can see how all these infectious diseases have been disappeared due to effective vaccination. So the efficacy of vaccination is incredibly high and actually very low, with very low toxicity. So think about this: the risk of getting sick from vaccination, is 30 cases in 1.8, I think it's more than 10 million people vaccinated in our country, is a very, very low risk actually that I think, in my opinion, seems to be acceptable. The current bottlenecks for vaccination is the supply chain. I mentioned that we don't have enough doses. The distribution side and the logistics with storage and handling, website scheduling, eligibility. Lots of the websites are crashing right now because of the interest that people have in vaccination. And what's really concerning to me, what I'm talking to a lot of folks about, is convincing Americans to get inoculated. So a CNN poll found that about a third of Americans said they would not get the vaccine, even if it was affordable and available. And we really have to work on this, particularly as educators, to reduce this hesitancy and educate the benefits of vaccination. So what are the therapeutic agents? And I wanted to go only in two classes of agents: the monoclonal antibodies and the vaccines. I'm talking about that. I also think that dexamethasone for acutely ill patients have played a big role to mitigate the effects of COVID. Also, it's really important for respiratory illnesses that are COVID-induced. And the antivirals, it's not, remdesivir was the first, drug approved, but it's only, for patients with mild symptoms. And honestly, I think the indications are very, very limited for those antivirals that will be replaced with either monoclonals or with vaccines that are currently on the market. Here, I wanted to show you the vaccine candidates that have moved now into clinical settings. I'm talking about the Moderna and the Pfizer vaccine that are already out there. But there are other vaccines that, particularly China has used. They used inactivated vaccine products, and the Sinovac product is actually very effective. We will never see those vaccines because they're in China. And with our relationship with China, there are significant hurdles getting these vaccines on board. And right now, it's not even a problem right now because these vaccines here, these RNA vaccines that have shown great efficacy, are now sufficient amounts have been purchased to vaccinate the entire US population. I'm excited about mRNA vaccines because, we used them actually 10 years ago against a variety of infectious diseases and for cancer. So it's not a new platform, but it's the first time it has been distributed so widely. You can see that both vaccines, whether you get Pfizer or Moderna, they are highly effective. They have been validated in phase 3 clinical trials of similar sample size. The age criteria were similar, so these were folks greater than 16 or 18. The timing is a little bit different. Pfizer requires a revaccination after 3 weeks, Moderna after 4 weeks. But what makes it a little bit different is the dosing and the storage temperature, which gives Moderna an advantage to be broader distributed. So you don't have to cool them down as much as the Pfizer vaccine. And also you get more doses per vial out of the Moderna vaccine, which makes it easier to handle. So long term, I think Moderna will probably be more broadly applied than Pfizer, and not giving any preference to any of those. Myself, I received the Pfizer drug, did well, and it was great to get access to a vaccine, but I can tell you that the distribution is much more complicated, particularly in outpatient settings where you have to bring the vaccine in from really minus 94 degrees storage into a community setting and really vaccinate within a certain time frame. Otherwise, your vaccine is not effective anymore. The next vaccine that's expected in the United States is the J&J vaccine. It's a one-shot vaccine, which actually allows us to vaccinate more people. It's a adenovirus that also encodes the spike protein, which is the attachment protein of the virus to human cells. Also, the distribution is probably easier. It's stable for -4 degrees and at least for 3 months. So I think that's actually something what J&J has worked on. And I expect the approval starting in February of basically next month. So the data are in, and the FDA is reviewing the data for efficacy. And then once that is released, I think they will get approved. They're looking also at the treatment of symptomatic patients, and they're looking at scale up, which is really important right now. Monoclonal antibodies, I'm not too excited about this, although they have been administered to our prior president and others, the Regeneron vaccine. And it seems like that these vaccines can mitigate mortality and symptoms, although it's not totally clear, what the long-term effects of these antibodies are. But what it does is these antibodies bind to the virus and inhibit penetration of the virus into the human, particularly respiratory tract. And that's kind of the mechanism that's being targeted. I think that the initial Regeneron vaccine had 2 antibodies, so 2 binding sites. This one, the Lilly, has only 1, and they claim similar efficacy. AstraZeneca is coming out with something very, very soon. So these are also on the market, but again, they don't compete with the vaccine in terms of efficacy, and only reserved to patients who already have symptoms, particularly mild symptoms. So I want to talk briefly, I'm coming to the end, to the COVID variants. And, I love this slide here because I know what this all means, these things, but I can tell you there are 2 things that you have to know. So there is the UK variant right now that is highly detectable by PCR, and we can really look at it. What the UK variant does is it has a higher affinity to a receptor on your respiratory cells that allows it to bind better. So the issue is that so it becomes more infectious, which also highlights, the importance of masks, because if you wear a mask or double mask, this is, you're not in danger, but this is a virus that binds more to your cells and infects you quicker than the wild type COVID-19 that we identified before. So it also is known in preliminary studies that the vaccines still work against the British variant. And there is, I think that it's now becoming the more predominant variant in the United States as we move along because of selection. But I'm convinced that all the vaccine products that are coming on the market will handle this particular variant. I'm more concerned about the South African and Brazilian variant because we can not detect it as readily as the British variant. And we also know that this Brazilian and South African variant is more tolerant to the monoclonal antibodies here. So there are some data to show that both the Regeneron and the Lilly antibody does not work for those variants. And we don't know yet how the vaccines work, but I'm pretty convinced that they still work, maybe not as much as against the wild type, but these vaccines here, they're still very effective. And I think that once we reach herd immunity, then also these variants stop producing. So variants only emerge if you have still enough virus in the population. And the more we move forward with mitigating the viral load among our population, I think the more effective we will be. This is Biden's plan, and I think that it's a good plan without being political, because we're taking this very serious. I think he has mandated masking for 100 days in federal buildings and in airplanes, and when going across borders. There's a new process that converts a very decentralized, very market-driven approach rollout to a more centralized, federalized plan with increased vaccine production. Now we have 300 million vaccines for everybody, which is great. We are also widening the eligibility criteria, and we're developing mass vaccination sites, and hopefully we achieving here more uniformity and flexibility in vaccine distribution within a short time period. So I think by summer, if this all works, by summer, everybody should get vaccinated, should be vaccinated, and we should see a significant decline in cases and mortality as we go along. And the last slide is just some information that I think is important, and these are evidence-based information sources that I recommend. And you can see here that that case and death numbers may vary according to source. Its trends, death, infection rates are more readily or reliable indicators than what typically all these outlets report. So this is my primer, and now I'm actually excited to hear your questions and answer any questions you may have. So I'm going here through the chat one by one. Can we please get copies of the slides? Of course you can. So I will send this to Shark Chats as a PDF, and this can be shared with everyone interested here. Can you send out the chart with the risk levels? Of course, it's included in this. Happy to do that. The Florida residency must be new. Yes, it is new. I know Holiday Park was recently distributing to non-Florida residents. It's an executive order that was recently issued by our governor. It is new, and you just have to be aware of that when you ask your friends from out of state to come to Florida vaccination sites. And it's worthwhile to track the orders of through the Surgeon General and through his website. What's going on right now in our state. Jean Walder asked, does one vaccine over the other have higher side effects on the second dose? That's a very good question, and I can tell you that the side effects are pretty much similar from vaccine to vaccine, but it's very dependent on the individual. I can tell you from my own experience, the second vaccine is knocked me out. I mean, I was sick for a day. I mean, it was flu-like symptoms and fever, but what's expected, after the second vaccine is that your B cells, which are immune cells in your body, produce more antibody, and they're kind of, it's almost like a fever. It feels like the flu. It's also affects your bone marrow to produce more B cells. So I think you have a lot of activity in your body that is stressed to produce more antibodies after the second shot. So you may experience, if the first shot is typically well tolerated, with a little bit sore arm, because you inject, the DNA, the RNA into the arm. So I think there's a little bit of mini inflammation going on there, but I think the systemic effects that affect your immune cells in your body become more apparent after the second dose. So I would say that the one vaccine is not better than the other. It really depends on your immune susceptibility. And actually, if you have side effects after the second vaccine, it's a good sign that you react to this and that you might be immune to the vaccination, which exactly that's what you want. So hi, Kyle, I saw your question here. Once inoculated, can an individual still transmit the virus to others without appropriate protection? So is this why we won't vaccinate? Do you still continue face coverings, etc.? Good question. And I think the issue is that once inoculated, even for the second time, it takes a couple of weeks until you reach your peak immunity as measured by antibody levels as well as T cells in your body. So the timing of your full protection is not clear yet, and it depends from patient to patient. So you can transmit the virus to others, unless you have enough systemic immunity in your body, but I cannot tell you and predict on an individual basis when that occurs. So we still recommend to wear the mask for quite some time. Also, I think it's a good behavioral tool. When I go on Las Olas, nobody's wearing a mask, and I'm very disappointed about this. I think we should be role models, wearing the mask, whether we need it or not. And I think that's a good thing. And by summer, or maybe in the next 100 days, I think we can wean our mask off. But right now, I just would like to encourage everyone to wear a mask, whether you're vaccinated or not. Question number 2, what if a person doesn't get a booster at the prescribed 3-4 week date? What is if they get it with 6 weeks? So very good question. I have to say I'm a little bit less concerned. So I did a lot of prime boost studies on patients. So the issue is just the primary recommendation that CDC issues is based on the clinical trial design. And the clinical trial design was, either a boost after 3 or 4 weeks, as I showed in the previous slide. But I think it is conceivable, we don't have the data yet, that even after 5 or 6 weeks, you get a pretty good recall response. So the prime means you prime your immune system. That means that you have a reservoir of B cells or T cells. These are the lymphocytes that you have in your bloodstream that recognize the virus. So the recognition is instigated or is initiated with a prime dose, with the first dose. Once you put a second dose up, then we call it the recall response that goes along with a massive expansion of immune cells and antibodies that really make you immune to the virus. So when it's going to happen is highly dependent on the individual. I would go with the prescribed dose. I don't think it's advisable to delay revaccination, and I would insist getting my revaccination, the second shot, at either 3 or 4 weeks as prescribed, because that gives you the evidence-based answer, when to take it. But it could work, with 6 weeks as well. I think that question will be obsolete as more vaccine come on board. And I'm pretty convinced that in 2-3 weeks, I think we will be okay with vaccine supplies. Laurel Haskamp asked, are any of the vaccines the same type as traditional vaccines, or they're all mRNA? So the traditional vaccine typically is an attenuated virus. Yeah, so you just inject dead virus in the body, and you think that that virus is recognized by immune systems, by dendritic cells and other immune cells, and that's what the Chinese vaccines do. We will never go back to those. There have been, the attenuation of a virus is still risky. That there's some live virus in there, and nobody wants to risk that. So I think we all moved now to more safer vaccines that, don't even have viral products anymore, except for, the mRNA vaccines encode only for a small component of the virus that is responsible for the adhesion to human cells. So all the vaccines, target this kind of particular structure on the virus. So the mRNA vaccines, mRNA goes to DNA, and that's going to be produced into a protein, and that protein is then gobbled up by immune cells, and they recognize, oh, here's danger. So this is how mRNA vaccines work. The Johnson & Johnson vaccine, what I mentioned, which is the third vaccine that's coming on the market, is an adenovirus. That's a pseudovirus, basically truncated, crippled, that puts the genetic information for the spike protein in the human body. So it's still being produced inside your cells. So the mechanisms are quite similar. It's just the delivery of the information of the virus is different. In one case with mRNA, in the other one with a virus that's packaged in an adenovirus. So it's in the end, it's probably all the same, and it's all effective in the same way, but they all target the spike protein, which is the key vulnerability of the COVID virus. Robin McCrae, can this PowerPoint present when this ends? Sure, I'm send it over to Carlos Perez for distribution. Through various effective vaccines are available in curative, do you feel that the emergence of variants, we need to invest research on the repurposed drugs under extreme conditions? So Venk, you're a researcher, and of course, research is important. We shouldn't do anything without research, and we shouldn't do anything evidence-based. And I think that, especially with the CARES Act funding that our government is releasing as we speak, there are lots of opportunity to research more, what variants, how do we deal with the variants that could be, potentially harmful to, our citizens here. And I think the more insights we have on these variants, the better we are off. But I think that the biggest effect that is accomplishable in the summer of this year is just to get everybody vaccinated and get the viral numbers down in our population so that we reach herd immunity. And then I think all the problems, even with the variants, will disappear. So that's kind of an optimistic view. But I think that's what's typically happened with these viral outbreaks, that once you get immunity in patients, at a level of 60 to 80% in the population, I think then we have less problems with viral mutants, because there's just not enough virus in the population to mutate anymore. How long do you predict, this is Elizabeth Trophy-Chuk, how long do you predict it will take for vaccines to be available for children and younger than 16 years? So I think these studies are going on as we speak. We know that children have actually less symptoms. I mean, some got sick, but they have been shown to be carriers for COVID. I think the studies right now, particularly with Moderna in children, are ongoing. And I think that we will have some data very, very soon. But again, think about it. So children are, a significant amount of our population. But once we get the viral load under those conditions down, the data on children will come in. And I think that at that point in the summer, children will be able to receive vaccine as well. That's not a promise, but I know that this has been debated, at the NIH, and particularly by Dr. Fauci, who mentioned that, the current indication for the 2 vaccines are being extended into children with all the precaution that it takes, for younger kids to receive vaccines like that. So that's in process, and that I think will be realized towards the summer. Louis Cohen, if one has remained at home for many months and is a believer in 1 injection over 2, would it be reasonable to wait for the Johnson & Johnson once injection, as it could help against a variant? Also, I have severe responses with injection and blood draws. Would it be better to wait? My answer is no. It is not advisable to wait. I think it's advisable to, perform a thorough history and physical, look at your, adverse effects. If you have severe allergic reaction, the current recommendation is to monitor you after vaccination in a hospital setting for 30 minutes. If you don't have any side effects after 30 minutes, you are home free. And I just would like to recommend, get your doses as prescribed and deal with your side effects or with your, allergies, in a more monitored environment. I think this is really important. And particularly if you have other health issues, once you get vaccinated for the second time, you don't have to worry about the virus anymore, and that you can focus on things, what you do. I also want to mention that remaining at home doesn't protect you from COVID. And actually has been shown that if you stay home and if you have kids and family and older adults, mingling with you, that most of the transmissions actually happen at home today. So a lot of our faculty here at NSU are asking, well, I would like to stay at home to be better protected, but it's not the case that you're better protected at home than as if you would be here under, the appropriate precautions, including hand washings and masking. So I just wanted to tackle that rumor that staying at home protects you from COVID. When do you expect children to get a vaccine? As I mentioned, this is still speculatory, but the studies are underway with one of the vaccines that are already on the market. I think that in the summer it might be reasonable to expect children to get vaccinated as well. The issue is that by then, I think we have already sufficient herd immunity so that the viral load or the viral distribution in our population will go down, and that we will see less infected cases, and that also children will be less susceptible to acquire the virus under those circumstances. Vaccine trials begin for pediatrics. I mean, they already have been rolled out and they're ongoing as we speak. I'm just waiting for the data to be released. How necessary is the vaccine for someone who had COVID already? I think that it's a very good question. If you have COVID antibodies, you should be immune. You still can get vaccinated, by the way. And I would just recommend getting vaccinated anyway. Even if this is not evidence-based yet because there's no study done to vaccinate COVID-infected individuals. If you have had COVID, and if you have measurable antibodies in your system that is detectable through ELISAs and others, you should be protected. I still would recommend to go through vaccination. It's an additional layer of safety, but this is not recommended by the CDC at this point because the eligibility criteria for COVID-infected individuals have not been, or the eligibility criteria for vaccines have not been extended to COVID individuals yet. So this is something that will be addressed also, later on. Do you think that NSU will secure vaccines for all students, faculty, and staff? My answer is yes, Andrea. So we are now officially part of the Florida Shots program, and will become a vaccination site. At least the president announced this, among the deans, that we will become a vaccination site on the East Campus. At least that's the plan. We have not received an allotment for vaccination. So this will be forthcoming, and I think that this will be a resource for all of us, students, faculty, and staff. And I'm 100% sure that Dr. Hanbury will update you regarding our progress on our internal vaccination program very, very soon. That's Simone Francis asks, is this current vaccine really effective, knowing that there are strains that are new? The vaccines, all the data show that despite of the strains and despite of the mutants, the vaccine is still effective. It may not be 95% effective, but 90%. So you have only a 10% chance that it may not work. But typically they work. And I would recommend to go for the vaccine as soon as you can, and as soon as the criteria have been loosened up, so that even folks below, younger individuals and non-healthcare professionals can receive the vaccine. To someone with Deborah Lyman asked, do someone at the age of 85 should be able to be vaccinated when? Of course, everybody should get vaccinated, and as soon as the restrictions have to focus on seniors greater 65 have been lifted, you should get vaccinated. I also want to tell you that hospitals have about 10% surplus of vaccine that can be given, and you should, just be aware that, the hospitals accept appointments. They will not accept you if you say you're 58 at this point, but they will very soon. And I would just contact your regional hospital that has vaccine supplies to get an appointment or put you on the wait list. I think that would be a good idea. There's Larry Behar. Is there conflict between receiving one vaccine brand and then another? He's moving from Holiday Park to Snyder Park. No, you should stay with the same vaccine brand. There are studies undertaken to look. So I have to say that each vaccine is targeting the spike protein, but when you look at the molecular distribution of how how immunity is being generated, so these the stimulation of B and T cells is predicated on so-called epitopes, and epitopes are 9, 10 amino acids long, so they are very, very small. So it's pretty conceivable that either vaccine is tackling different epitopes that creates a different type of immunity or a different type of monoclonals. And at this point, I would not recommend a mix, but it would be a great experience to show what it does. We have not received the data yet, and I think this is something what we need to look at down the road. There are some in vitro experiments that have been done that showed that 2 different types of immunity have been generated, and that the immunity is not potentiated. So it's just you're creating a broader immune response, but it's not sufficient magnitude to combat the virus more effectively. So that's my comment to that. There's Mr. Graham or Mrs. Graham. If you have had COVID, do you have to wait before receiving the vaccine? At this point, you have to wait, yes. And the CDC, that's kind of also part of the Biden rollout, will provide guidance when you are eligible to get vaccinated. So I would really look at the CDC website to look how the restrictions are evolving. I think the next wave will deal with patients with comorbidities. If you have severe COPD or heart disease or diabetes, I think you will be the next rollout target that I would expect to be able to get vaccinated within weeks. That's my expectation based on my conversation with the Surgeon General. Another one, if you have already contacted COVID and recovered, are there any consideration for the timing and diversion of the vaccine? Yeah, I think you should definitely measure, antibody levels in blood. If you have detectable antibody, there's no rush to get vaccinated. If you don't have antibodies, I would consider you for revaccination with a COVID vaccine. Again, not a reality yet, and it's not considered right now according to the CDC guidelines. But I can tell you that this is just common sense recommendations, and I think that's going to happen once the next wave of vaccines, once vaccines become more broadly available. Melanie Mariani, I know that many healthcare providers with patient contact are getting the vaccine. Is there any information available about healthcare students, OT, PD, nursing, who have direct patient contact be able to get the vaccine? So what I heard from the Surgeon General, that anyone, whether you're a physician or a nurse, or whether you are a healthcare provider with direct patient contact, you should be able to get the vaccine. So you are in the current priority, and you should ask the hospital that you work in to get vaccinated. So that is totally consistent with the governor's executive orders. And if the hospital, turns you down, they can only turn you down because they run out of vaccine, but you are eligible and you should receive the vaccine. We have similar conversation about our students with direct patient contact. It's much tougher if you are, in a isolated room without patient contact. Then this will be included in the next wave of eligibility. Will vaccination be required at some point? I don't think so, to be honest to you. This is kind of a legal issue. It is clear, though, that health environments like hospitals can require vaccination. So at the University of Florida and other places where I've been, they have mandatory flu vaccinations that are expected from the health personnel. We are not that far because we didn't really have enough vaccine supply yet, but that's entirely up to the hospital to require immunization. But I think a more broader order from government to get vaccinated, in my opinion, will not happen. It will be focused on healthcare environments that are dealing with sick people. So that's I think restricted to those environments here in terms of requirements. What is the benefit for being vaccinated after having the virus if you already have antibodies? As I said, if you have, at this point, you're not eligible, but if you have antibodies, you should be protected and you will fall probably down in the priority list to get vaccinated. I still think that, what we know is that these antibodies are swirling around for 90 to 100 days. And as long as these antibodies are there, I think you should be protected, and I have less concern for you to get sick. I still think there is, if these antibodies go away, I think you should receive a vaccine long term. That's, again, my recommendation as a physician, but it's not consistent with the executive order that prioritizes a certain population at this point. Any upcoming updates, if NSU will provide vaccination to its staff, faculty, students? Yeah, I think what we did is we already put out a FAQ site on, on frequent questions that everybody has. So I would study the NSU site. And, of course, I talked to Kyle Fisher in particular about the need to provide updates on a regular basis, either coming through the president or coming through healthcare providers. We have a lot of them here on campus. So I think that communication will be critical also to reach the new president's goal of, vaccinating everybody, 300,000 people by summer. And I think he said 100 shots, in 100 days. So these are ambitious goals. And I think we should assist reaching that goal here through frequent communications. And I'm quite sure that NSU will have roll out a communication plan as we become a vaccination site here at NSU on the East Campus. Simone Francis, I'm also hearing that one can get COVID again. Is that because of the new strain? Not necessarily. I mean, the new strain is one example, but it's also that your immunity may not be long lasting, with your current viral exposure. So it's an individual issue that some people have stronger immunities than others, and particularly those with comorbidities, or somebody who's immune compromised either develop no immunity or have short-lived immunity that needs to be either refreshed with a vaccine or protected. So it's not just the mutant, but also the individual able to mount an immune response. And the immune response is not only antibody-based, but also T-cell based. So there are two lines of defense in our body. One are the antibodies. The other one are, attack cells that are called T cells or T lymphocytes that attack the virus directly. So I think these are measurable, numbers in your blood that we can measure based on assays, and that also tells you, where you stand in your immune response against the virus. Karen is asking, how long after the second dose do you reach 95% immunity? I can tell you that immediately after the second dose, you have this huge expansion. I think that 2 weeks after the second dose, I think you are at your peak, as measured by antibodies. But as I said, antibodies, in my opinion, are just one measure of immunity. There are other cells that mediate immunity against the virus. But I think that after 2 weeks after the second dose, you're pretty well protected. Okay, Patricia Rose, what is the consequence to patient who received their first vaccine but couldn't get the second on time? Will they eventually have to retake the first vaccine if too much time has elapsed? So good question. I hope it hasn't happened to you. And I think we are doing everything possible. Even the governor is reserving now a contingency of vaccine for the second dose. So we can't touch the second dose for first dose recipients right now. I don't think that we will have vaccine on time for the second dose. I think that there's a lot of concern at the governmental level also to make second dose vaccines available. If it happened, getting beyond the 3 or 4 week vaccination scheme may not compromise, your immunity, but if you let's say if we would run out of vaccine for 2 months or 3 months, I think yes, then you have to be primed again and you have to go through the cycle again. But this is all theoretical, and I think it's unlikely to happen. As I said, second doses are reserved now for second dose recipients, and you should tell your vaccination site you're a second dose recipient, because it's a different lot of vaccine that's set aside and cannot be utilized for first dose recipients. Sheila mentioned, do we wear masks after the shot? For how long? I think right now we wear masks. So in theory, as I mentioned, 2 weeks after the second shot, you should have maximum protection. I think, in view of the mask wearing protocols that the new president put forward, and also to educate our community, I personally wear a mask, when outside or when in crowded environments. And I think we should just be a role model to continue wearing masks for the next 100 days. That's what I'm recommending right now, just to make a change in the population and be a good example. Whether you need it for your own protection or not, I think it doesn't matter. Angela said, I got the first dose about 2 to 3 weeks ago, and I'm getting the second one today. Congratulations. And the only reaction I got was that I got extremely tired and my arm hurts a little bit. That's totally expected. Don't expect anything else. I think that, just step back a little bit. Don't overexert yourself. After the second shot, watch yourself for anything else. But the fact that you have some symptoms here is actually a good sign. And I'm just glad you got your second shot, and hopefully you're protected in a few weeks from now on. Sylvia Kasparian mentioned, in California, what happens if there's a shortage of the Pfizer vaccine and it is not distributed for the second dose? Is there enough for the second dose? As I said, the president of the United States secured actually 300 million doses of vaccine. I think that that's a great accomplishment. I do not know how fast these doses are being distributed, but yes, we have a shortage right now, and some of the first vaccination sites appointments have been canceled because of the uncertainty. There's enough second dose vaccines here in Florida available. I don't know what's happening in California, but I think that, we shouldn't get in a panic right now. This is a day-to-day progress here right now, and the news change day to day, and I wouldn't really, go into a crisis mode right now, because tomorrow we will be different. If there is a shortage, then we need to deal with that, and there will be CDC guidance coming forward, if we run out of vaccine, which I don't really expect. So just hang in there. There's more supply chain coming forward, and I think we are now, since government stepped up with their measures, as shown in my slide, I think I'm more confident that we will get through this here. There's Jerry Stryker, welcome. Can you share more about a plan to widen eligibility? Your insights given 65 and population below to get herd immunity. So, it's not my plan, but as I mentioned, Gary, that within the next 2 weeks, the eligibility criteria will be broadened. It also based on better supply. In speaking to the governor, he wants to finish here in Florida, age 65, and get them all vaccinated, and then roll out more to the general population. It also will happen through the distribution of vaccine to CDC and Walgreens and to other vaccination sites. As I mentioned, Disney, churches, and other sites will open up here fairly quickly. In my slide, I mentioned, some of the vaccination sites that have already opened here in Broward County, and more to come. So I just personally watching CDC and contact every day my trusted sources in the DOH, to find out where you can receive vaccine and when the eligibility criteria open up again. So Gary, I'm happy to talk to you more about this offline. There's Kendra Pennington. Is there any research or how long the vaccine will be effective for? I think there's already a lot of published data out there, particularly in the Moderna vaccine, that shows that there are antibodies visible for, detectable for 100 days. Again, that means actually there's a New England Journal of Medicine article right now that shows actually long-lasting effects or protection of the Moderna vaccine. Have not seen a lot on the Pfizer vaccine recently, but I would expect the outcomes to be the same. But think about it. These studies only look at antibodies, and it's not indicative necessarily what immunity entails. So immunity is not just based on antibodies, but it's a very easy way to measure immunity, using that particular marker. So that's kind of the research that's ongoing. And long-term, as part of the vaccine development plan, it is mandated that each vaccine producer is producing long-term data, and they are typically published, in medical journals, or come into the news, or are being also broadcasted by government agencies, whether it's here in Florida or elsewhere. So I think this information will be forthcoming. How will herd immunity be determined? Good point. I mean, we're not determining it. We will actually see it based on the numbers of people who have received the vaccine, and also on a reduction of cases that we will observe. So I think that, we already see less cases but towards the end of January, which is, probably an effect of, more social distancing and mask wearing. I think that the case numbers will go down. And again, as I mentioned, if there's immunity in more than 60 to 80% of the population, so the gray zone between 60 and 80%, the virus will eventually die, and the mutants will die, and there will be no mutation. So there is a light at the end of the tunnel. We just have to reach a certain threshold of immunity in our population. Aura mentioned, what is the recommendation for population under 65 with autoimmune conditions like MS, allergies, and antibodies and asthma? It's a simple answer: to get vaccinated as soon as possible. And as soon as the CDC criteria open up for vaccination for high-risk individuals or folks with, secondary or comorbidities, which I expect very soon to happen, you should get in line and should get an appointment, and you should get vaccinated. That's my take on that. Jennifer mentioned, can you speak about the duration of how long the vaccination protects us? As I mentioned, 100 days in vitro data. So you're protected for quite some time. But as I said, the real protection is not determined by the amount of antibodies that we measure. I would expect, if you have received 2 doses of vaccine, that this response will last for a year, bottom line. It's like with flu. You may get revaccinated the following year, but I think that you should be safe for a year. That's my expectation based on, other viral disease settings. Leo Tomos is asking, what's the best way to get the vaccine for age 65 plus to get an appointment? There are plenty of appointments. I put one of my slides, and you can ask those vaccination sites to get an appointment. They accept appointments, and there's no restriction if you're 65 and older. Is it true that vitamin D are useful for prevention or strengthening the immune system? Unproven. It's, there's just a lot of stuff out there. If you have the appropriate amount of vitamin D in your system, which we should, I think that's a good thing, and it also affects your immune system, but there's no evidence at this point that excessive doses or more doses or supplements that carry vitamin D, are beneficial against COVID or anything else. Same thing as vitamin C or any other supplements that you can purchase over the counter. Christopher is asking, do we have good data on the length of protective immunity post-inoculation? So a lot of similar questions. So I want to skip on this one because I mentioned the in vitro data, suggests 100 days plus. I think that you have protective immunity with a effective vaccination, if you fall under the 95% who had a good response to COVID, that you're protected for about a year and you don't have to think about this, but you will have to think about this the following year. So, and I'm still on alert, how this, once we reach herd immunity, how this affects, as we move along. Michaela Rizzo, are there any concerns with people getting the vaccine if they are on medications that suppress the immune system? Wholly yes. I mean, I'm very concerned about this because if you're immune compromised, it becomes a different issue. It also, your immune response is not as strong that might give you sufficient protection for the virus. So if you're on, for example, on steroids, I recommend, you have to think about, do I need the steroids or is this a medication that I really need or not? So you have to talk to your doctor, whether you can, have a steroid holiday for a while, or, how do you deal with that? So the issue is just the mRNA vaccines are not dangerous, but so you cannot get COVID from the vaccine, but your immune response to the vaccination might be weakened or maybe non-existing. So I think that's just something what has to be discussed, how to deal with patients on an individual basis. So that's, a very good question that, is very specific to the individual and their condition that they have. What are the studies on individuals with previous bone marrow transplant if vaccine affects bone marrow? So if you have a successful bone marrow transplant and if you should be fine and you should develop good immunity against anything. If you're still kind of in a state where your transplant is just, emerging, it's a different issue. So you have to talk to your doctor. I vaccinated folks right after bone marrow transplant in the early phases, and they developed good immunity to this, but it is very experimental and was done on a study protocol. So bone marrow transplant is not a contraindication to get vaccinated, but you have to talk to your doctor and be supervised. I did it under experimental protocols that worked really well, actually, in our case. But again, I don't want to make general recommendation to do that without having your interaction with your physician. Have you heard about any reactions to people with alpha-gal allergy? I read the vaccines are not made from animal products. No, they're not. I think that, allergic reactions are quite frequent in our population. The current recommendation is if you have any type of major allergy against either food or shellfish or anything else, you should be monitored for 30 instead of 15 minutes, and you should do that in a hospital setting. So you shouldn't go through a drive-through and wait for 30 minutes. You have to be vaccinated through a hospital site. So that's the recommendation right now. Okay, Kristen, should we worry about the long-term side effects? What? I think no. I mean, the issue is this vaccine doesn't have long-term side effects. I heard some concern from individuals since RNA is genetic information. Does it change my DNA or my, anything in my body? And the answer is no. The issue is as I said, from an effect standpoint, the RNA is translating the DNA into a protein which encodes for the spike protein of the virus. And that's basically eaten up by your immune cells, and there's nothing left. So I personally have about 30 years experience with RNA vaccines, and I think there is no long-term effect that we could detect. We even did PCR on patients long-term to look at mutations or inserts from the RNA, and we could not identify that. So that's not something what I would worry about. Susan Flax, after the second shot, should we use or try not to use fever reducers such as Tylenol or Advil? I think, you can use Tylenol, no problem with that if you have fever or something else. Somebody told me that Advil may mitigate the immune response. I have no data on this. I use Advil, if I have a headache or something like this. But the key recommendation for vaccine side effects is Tylenol, so you can use that without any problems. Renee, how are you? Everybody should continue to wear the mask until the variants are eradicated. Should they not? Yes, Renee, I think everybody should. And it's not just because of the variants. It's also because, you know, of the general population still has even wild-type COVID around, and we still have high numbers of infected folks around. And particularly if you work in more crowded environments, let's be a role model and use masks, and you know, do that for the next 100 days, as the president indicated. And I think we will see a dramatic improvement going on from there. Algibus, how are you? Is it known how long immunity lasts with either natural infection or via vaccine? As I said, you know, long-term studies indicate more than 100, 150 days. I can show you the reference in the New England Journal that was based on the Moderna vaccine. I think you're fine for 1 year. That's my assumption based on the data that I see to date. Another one, Deborah Cohen, do you recommend vaccination in individuals who were infected? I already mentioned that. It depends on your antibody configuration. Thank you for this presentation you provided. You shared experience influenced my decision about getting the vaccine, and I agree with you about smart. Thank you very much. I think that's kind of the best question I have, and it just shows that hopefully we made a difference and influencing folks, you know, to get vaccinated and move on from there. All right, I think I have to close. Unfortunately, I have another meeting going on, and you know, if I have to do this again, I'm glad to do that, but thanks for giving me opportunity, and I hope that everybody feels better a little bit after, you know, also in view of all the miscommunication that is happening around this area.
Thank you so much, Dr. Vivek, and all of you who have joined us today in the College of Psychology. Please note that we created the Shark Chat series. The programs are recorded. You can go on our website and find them. They have been on numerous topics over the course of COVID, and there may be many other programs you may be interested in listening to. A special thanks to Dr. Perez and his team for putting these together regularly, and I'll turn it to you, Carlos, to close.
Thank you so much, and probably one of the most interesting chats that we've had, and I have to compliment our presenter, his ability to answer so many questions, and we really appreciate this. This is it's very calming to hear your words. NSU, Nova Southeastern University, if you didn't know, we've got just a beautiful, amazing campus, Davie, Fort Lauderdale, Florida, and we've got undergrad programs, School of Education, law school, our medical programs, and of course the College of Psychology, which is the host. I want to mention to you that this chat series and the mission of NSU's College of Psychology are supported in part by the generosity of donors such as yourselves to the Brighter Day Mental Health Fund. And if you haven't, we encourage you to make a little gift, and you could do that with the text number that you see to just text the words NSU to 41444, or simply follow a link that's very simple, nova.edu/give. You could also contact Tom LaFleur and or even psychology@nova.edu. The video and the slides, we will email everyone within 24 hours, and we thank you so much. Please do share these. Our next session will be on February 12th. We've got a very extremely sensitive presentation on the 3rd year of Stoneman Douglas shooting, which in Grosby, I think we were together when we experienced that tragedy. And I hope you will share these events, and simply the website is nova.edu/sharkchats. Please stay in touch.